Welcome to the LDN radio show, brought to you by the LDN Research Trust. I'm your host, Linda Elseygood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose Naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. Would you like a consultation for an LDN prescription without leaving your home? Good news, ldndirect.com can do just that. Consultations are available in all 50 states and parts of Canada. They are waiting to help you improve your health. I'd like to welcome back my guest today, Dr. Sajad Zalzala, and most people call him Dr.Z. Thank you for joining us today, Sajad.
Oh, thanks for having me back. It's a pleasure.
Well, you have done wonderful things and you're very passionate about what you do. And you're now actually licensed in all 50 states and some states in Canada too. Perhaps you can tell us what's been happening in the telemed consultation field since the last 2 years when we spoke.
Yeah, so I think last time we spoke was back in early to mid 2018. So it's been almost 2 years by the time this show goes live. A lot of things have changed. The telemedicine regulations, are still evolving. But there's a lot of new players in the telemedicine field, prescribing, all sorts of types of medications that are kind of busy lobbying the regulatory bodies to help open up the telemedicine access.
Mm-hmm. And how many patients would you say you've actually seen since you started the telemedicine? Have you any idea?
Yeah, so I launched LDN Direct back probably in 2017 or late 2016. It was a slow go at first because I wasn't licensed in all 50 states, so unfortunately I had to turn away quite a few patients. But my most recent count is almost 1,000 patients.
Wow, that's a lot. It's a lot. And which states in Canada now can you prescribe?
So I'm licensed in Ontario, but that allows me to also do telemedicine prescriptions for patients in British Columbia and Manitoba.
Okay. And do you get many patients in Canada?
I get quite a few. Unfortunately, I get quite a few from Alberta, but I'm not licensed in Alberta, and they don't have the same agreement as British Columbia does. So unfortunately, I still have to turn away patients. Not very often. I mean, Alberta's not a big, it's not a very populous province. But it does seem to pop up more than one would expect to, considering, how few people, comparatively speaking, live there.
Mm-hmm. And will you be expanding into Canada in the near future?
I'm not quite sure. I've kind of reached the limit in terms of my appetite for applying for licenses and maintaining licenses and things like that. So I don't anticipate expanding Canadian coverage anytime soon myself. Mm-hmm. I'm looking at maybe seeing if a nurse practitioner licensed or another physician licensed in certain parts of Canada might be interested in helping. But that's a big maybe.
Mm-hmm. Okay. So for those 1,000 patients, do you keep any records of what conditions, what outcomes they have, or are you too busy?
I don't keep any. I would love to be able to, put it all together in a spreadsheet. That's kind of something that's on my list of things to do. But I have, I do have, I talk to patients based on what I see patterns, the patterns that I see for patients. Mm-hmm. So, when I get a patient with, for example, Hashimoto's, I see a lot of Hashimoto's patients, and I tell Hashimoto's patients what other Hashimoto patients have experienced with LDN. So feedback from patients is critical for me to continue helping other patients.
Definitely. And do you notice that the Hashimoto's patients who are on thyroid medication have to reduce that medication over time?
It depends. It kind of depends on a variety of different factors. I do warn them, especially if their Hashimoto's diagnosis is relatively recent, within the last, 10 years or less, or 5 years or less, I should say. I've had a few cases where patients start on LDN and all of a sudden they start getting hyperthyroid symptoms. And so I warn patients, all patients that I start on LDN who are on thyroid medication, to kind of keep an eye on their thyroid function, and to work with whoever prescribed thyroid medication to properly test and adjust the dose.
Mm-hmm. And how easy is it to have a telemed consultation with you?
I try to make it as easy as possible. On my site, there's a booking page, and I book patients for 15 minutes. And during that 15 minutes, I try to get all the information that I need to make a decision on whether I should prescribe LDN or not, and also what dose to start patients on.
Mm-hmm. And what dose typically do you start patients on?
For the vast majority of patients, I start them at 1.5 milligrams.
Mm-hmm.
But there are some clues that I look for when discussing it with patients to start patients on lower doses, significantly lower. Patients who tell me they have like sensitivities to substances, a lot of allergies, a lot of intolerances, or a history of Lyme or chronic migraines. Those are kind of red flags for me to start patients super low. 0.1 milligrams, 0.25 milligrams.
Mm-hmm.
But I tell patients, kind of the goal is to get around 4.5 milligrams. And if you look at the studies, that's where most of the studies kind of study LDN at. However, I'd say about 50% of people actually stick to 4.5, or I should say 50% of people find the 4.5 milligram dose the most effective. You've got, a good chunk of people who need a higher dose and a good chunk of people who do better on a lower dose.
Yes, I mean, years ago, the protocol then, when I first started, was 3 milligrams for the first month and then move up to 4.5. So you can imagine the dropout rate was quite high because 3 milligrams was just far too high for a lot of people to start with. And the dose probably that might have suited them long term was only 2 milligrams, So those
Sure.
people dropped out. Luckily, I was one of the ones that were fine with that protocol. But now, using a protocol similar to what you're using, the dropout rate seems to be very, very low. I mean, what do you find with patients? Do you lose many patients? Do they decide to stop taking?
I gauge my dropout rate based on my refill request rate.
Mm-hmm.
And it's about, some in the neighborhood of about 50% of patients come back and ask for refills. I don't know why the other 50% don't. I have some patients who, take LDN, they're doing well on it. They move, or they run into some issue, or some people just, decide to try without it, and then I lose them for like a year, and they come back and they want to go back at LDN. So, one of my plans down the line is to kind of poll all my patients and get a better idea of why people, are not coming back from refills. What's the situation? Are they getting it from their local doctor? That's happened several times. Where their local doctor won't start them on LDN because they're just not familiar enough with it. But after I start them on it and they're doing well, their local doctor seems a lot more open to refill it for them. Mm-hmm. So I suspect that might be another issue.
I think so. Like you say, some doctors don't know that much about LDN and they're very skeptical. but when they can see the evidence where a patient has been really sick and they haven't been able to do anything to help them, you know, and they've managed to get LDN and have improved vastly, that's encouraging for a prescriber to prescribe LDN, don't you think?
Oh yeah, absolutely, absolutely. I mean, I would be hard pressed to think that you know, a family doctor would deny a patient a request for a refill on something that they're doing so well on. Now, of course, there are doctors who still don't know enough about LDN, and there's also a big stigma around naltrexone because of its original FDA indication. That doctor's like, oh no, you know, I'm not a pain specialist, you know, you're not an addict, you know, I don't want to be flagged by the powers that be for putting people on naltrexone. So I think there's a lot of that. I think it's naltrexone suffers from guilt by association. It's used as an antidote for narcotics, and also for people who have issues with history of alcoholism, and so doctors automatically assume that it's only appropriate for those patients. However, what I find funny is that the FDA has actually approved naltrexone for weight loss in combination with Wellbutrin or bupropion. The combination is called Contrave. And so I find it funny that a lot of doctors who wouldn't prescribe LDN would probably prescribe Contrave if they were asked and if it was covered. But that's a different story. But you know, it is what it is. Doctors are a busy group, and they don't necessarily always have time to keep up with the latest and greatest. I'm guilty of that as well sometimes. We all get kind of stuck in our own little world, and sometimes that world doesn't include naltrexone for a lot of prescribers.
What about mental health issues? Have you prescribed LDN for, you know, traumatic brain injury or post-traumatic stress, anything along those lines, depression, manic depression?
Yeah, I've gotten more and more requests for LDN for those conditions. I can't say it's been a huge amount, but from the few patients that I have had and have checked back in with me, it does seem to help with those conditions.
Okay. And what about?
Which is a shame, because I'd like to see more. I'd like to see more of those patients because I think there's a lot of potential benefit for patients, especially with PTSD, where there aren't really very many medical options.
Yes. Well, maybe the people that are listening will decide to go and book a consultation with you to investigate further. But what about cancer patients? We know that LDN seems to work very well for some cancer patients. Do you get involved with that side of it, working alongside of patients' doctors?
I have prescribed LDN when requested to for patients with various types of cancer. Again, I can't say it's a huge part of my LDN prescribing practice, but like you mentioned, there's a lot of promising data out there that it might help. With any condition, I tell patients, there aren't any huge studies yet, and there probably won't be because it's a generic medication. But it's got very few interactions with other medications. There's almost zero toxicity. The side effect profile is pretty well known and pretty benign. There's really no reason why somebody shouldn't try LDN for various different conditions.
Have I lost you? Hello?
No, sorry. Does that answer your question?
Yes, sorry. I just thought I'd lost you there. So
No.
For the patients you mentioned, Hashimoto's, a nice new one that we have learnt about the last few months has been mast cell activation syndrome. Have you come across that in your practice?
I've had several patients recently come to me about that. Mast cell and then POTS is another one that I've seen quite a bit recently. And then EDS, acquired EDS, which don't ask me to pronounce it. It's a collagen synthesis issue. Originally thought to be genetic, but apparently there's an acquired form of it that a lot of patients get.
Ehlers-Danlos syndrome?
Yes, exactly. Yep. Ehlers-Danlos syndrome. I could never pronounce it properly. So, but I've had small influx of patients asking about that, and I've had some good feedback on those patients.
Good. Well, what about gut issues? Ulcerative colitis, Crohn's disease, celiac, irritable bowel?
I've never really had much experience with celiac disease per se. I don't think anybody's really asked me about celiac and LDN. I'm not sure if that. I just don't have an experience with it. It's possible it could help, but I was talking to an integrative physician at a conference once. He's like, nothing works for celiac disease except for gluten. Staying away from gluten. But in terms of like other GI issues, I've had a lot of people with either IBS as their primary, irritable bowel syndrome as their primary symptom, or as part of their larger syndrome, the part of their larger symptom syndrome, and I've gotten some really good feedback on it. And there are the studies that that show that Crohn's and ulcerative colitis patients do pretty well with LDN.
Definitely.
The caveat there is a lot of times they have a hard time tolerating the tablets or sometimes even the capsules. So I would, sometimes if I see patients who have, really bad gastrointestinal symptoms, I would recommend the liquid preparation.
Or the sublingual.
Yes. So those are becoming a little bit more popular. But the vast majority of patients, I'd say at least 90% of my patients can tolerate the capsules or tablets fine. And that's usually where I start because it is the most cost effective.
And what age group do you treat? Do you treat, from the cradle to the grave, or do you only treat adults?
I say that I only treat adults, but on request, sometimes I would think about helping older children. 12 is my cutoff. So I'd only really do 12 and older, and only if the parent's available during the consultation. There are some potential medical legal issues when treating minors. But on the other hand, they benefit quite a bit from LDN. So I try to accommodate as much as I can within reason.
Type 1 diabetes. Have you treated anybody with that?
The thing with type 1 diabetes is if it's not caught in time, it might be a little bit too late for that. I've had a couple patients, but I haven't heard back from them yet, where they were newly diagnosed with type 1 diabetes and I started them in LDN. But theoretically it should work because if you can stop the autoimmune attack on the pancreas and the pancreas is not too far gone, it is possible maybe to recover. Theoretically, I mean, this is all theoretical. Recover some pancreatic function if you catch it soon enough. But to me, that's kind of, from my perspective, that's kind of extrapolating from the Hashimoto's group, because Hashimoto's is analogous in many ways to type 1 diabetes.
Okay.
Yeah. So, but I haven't had too much experience. I mean, have you heard any cases or seen it yourself?
A few people that have told me it's worked very, very well. And I can remember several years ago now, a doctor whose wife and daughter had MS, and he was a type 1 diabetic, and he had for years neuropathy in his feet, and he had no feeling in his feet. And he thought, his daughter and his wife were doing so well on LDN that he would take it himself.
Mm-hmm.
And it was amazing. His
Really?
diabetic neuropathy just went. He was amazed. And he'd had it like 20 years, something like that. It was an awfully long time. But suddenly, to get all the feeling back in your feet, he was
That is
absolutely
amazing.
amazed.
Yeah, I mean, I'm always surprised on the stories that I hear from patients on LDN. I mean, I get a lot of patients who've been on LDN for a few years or many years sometimes, and they move and they can't find a refilling prescriber, or their insurance changes or something, and they come see me, and I'm always glad to be able to help those patients just because of how well they're doing on the LDN.
And of course, LDN works really well for skin conditions like alopecia, psoriasis, Behçet syndrome, vertigo.
Mm-hmm.
I'm just trying to think of all the other unusual ones. Hailey-Hailey's
Sure.
disease, and there've been
Yeah,
quite a few
I have a couple
studies.
patients. I'm
And
sorry.
Hailey-Hailey's disease has had some very good studies done,
Sure.
which
Sure.
has
I've
been
seen a few
amazing.
patients with hidradenitis suppurativa, HS.
Hmm.
And I've had a couple patients, and at least one of them is doing pretty well with the LDN.
It's amazing, isn't it? And what?
It is, and I mean, it all comes back to the immune system. Whether it's Hashimoto's, where we can identify the antibodies, or maybe even something like chronic fatigue or fibromyalgia, where we haven't really been able to identify any specific antibodies. I think it all comes back to the immune system, just balancing the immune system and reducing inflammation.
Hmm. And what about allergies? I mean, there are so many people in the US, I've noticed on my trips there, that seem to watch the television, how high the allergy rating is, or what do you call it over there?
Yeah, like the allergy score or the allergy
That's it.
index,
Hmm.
as
Yeah, and it really
sometimes
does
referred to.
affect some people, doesn't it? The air quality.
Oh yeah, absolutely, absolutely. We've got the allergic triad, the atopic dermatitis, eczema. You've got the allergic rhinitis, which is the runny nose and congestion. Then you've got asthma, or also known as atopic bronchitis, and so I mean, a lot of patients have one or more of those, and I've treated those patients with LDN. I can't say everybody has responded, just like any condition, but I've seen it work enough times to definitely recommend it for patients with any of those what's called the atopic conditions.
It's quite amazing. What about the topical cream? Do you ever prescribe that?
You mean for skin conditions?
Yes.
I have not yet. Can't say I've had too much experience with the cream yet. The only time I've ever prescribed topical LDN are people who just haven't been able to tolerate oral LDN for whatever reason. And those are kind of few and far between.
So when a patient comes to see you or consult with you, how do you find out whether they are suitable to take LDN? What criteria do they have to meet?
To be honest, like I mentioned before, LDN is just such a safe medication that doesn't really interact with very much. I can't say I turn away too many patients when it comes to prescribing LDN. It usually just comes down to the dose form and the starting dose. In terms of a matter of prescribing consideration. I suppose really the only time I would hesitate to prescribe LDN is somebody who's severely ill. I don't get that. I can't remember the last time I saw somebody who was like severely ill. But if somebody has like really advanced stage 4 disease, cancer disease, or or some really serious infection issue, I may hesitate to prescribe for those patients, just because you don't want to do any harm, and because these patients are on a lot of medication, even though theoretically there's not really any interaction, but it's always really hard to be 100% sure. And then the other times I wouldn't prescribe if anybody on chronic pain medication, Suboxone, methadone, if they're kind of dependent on, Percocets or, oxycodone of any sort. I would tell patients that there's interaction there, and there are some doctors that kind of prescribe like ultra low dose, for chronic pain patients, but I think those patients require too close of monitoring for me to be able to prescribe LDN through telemedicine.
The other thing, we're not going to be talking about low dose naltrexone now, but full dose naltrexone. Do you help any patients with the Sinclair method who are suffering from alcohol use disorder?
I don't advertise that I do, but I've had a few patients email me and ask me, and again, given that naltrexone is a pretty safe drug, even at the higher dose, I don't, I've definitely prescribed it before on request.
And the success rate, as far as I have heard from prescribers that prescribe the Sinclair method, that the results have been amazing. And I've actually spoken to many patients. I mean, to be hooked on alcohol is devastating, not just for the person, but for the family as well. And to have something that you're not told you've got to give up alcohol. You don't have to give up alcohol. You take the tablet, I think it's, don't quote me, I can't remember, is it an hour or 2 hours before you drink alcohol? But it stops you from having that craving. You take the alcohol and you don't get that effect that you would normally get. And then people tell me where, they were just at the end of the day craving for a drink. They would still go home, take the tablet beforehand, get the drink, and where they'd have to drink several before they would slow down. They would take a drink, go off and do something, drink a bit more without having to drain the glass. And I just think that's amazing.
Yeah, that's what the FDA indication of naltrexone is to help treat alcoholism. And it surprises me that addiction doctors don't use it more. And I'm not quite sure why. I mean,
but it's
you've
not
spoken to any addiction specialist?
Yeah, I have, but it's not used in the same way that it was approved for at the time. Whether you took 150 milligram tablet, 50 milligram tablets 3 times a day, so you were taking 150. Now, I have spoken to some people who followed that protocol, and it just blocks all your endorphins completely.
Yeah.
So these people just feel wiped out, empty, flat, and it's unbearable.
I can definitely see that.
They can't mentally cope with it. But by just doing the targeting dose with the Sinclair method, you don't get that total blank, empty feeling. You can still function as normal. So
I can definitely see that.
I just think it is great. But there are many doctors who are prescribing it, using it, the targeted dose, which is the Sinclair method, with great success. And there are some doctors who are also using low-dose naltrexone for alcohol addiction, or alcohol use disorder, it's called now. But I don't know whether it's strong enough. Perhaps it's dependent on how long people have been hooked to the alcohol. I don't know. But I do know that there are some people that need a stronger dose. And a lot of them do transition to low-dose naltrexone once they've stopped needing the 50 milligrams. But I must admit, I'm getting older now, and I was never a drinker anyway. But I could go out and have probably 2 or 3 drinks. But once I can go out now and have 1 drink and really enjoy it, but I really don't want a second. You know,
Sure.
it has no appeal. I would rather just have, you know, a soft drink, but not alcohol. But many people have told me on LDN, you know, everything in moderation, but they've found that over a period of time, alcohol isn't something that they desire. Put it that way. So I don't know.
Right. I mean, that's also in line with, you know, some of the things I see for patients who have issues with any kind of cravings. Food cravings too. Like I mentioned earlier, I mean, Contrave is a combination of bupropion and naltrexone, you know, FDA approved to help with weight loss. But, you know, a lot of people have a hard time tolerating the Wellbutrin part of the Contrave. And so I've had several patients come to me and say, hey, my doctor started me on Contrave. It worked really well for my appetite, but I can't tolerate the bupropion part. So I put them on a slightly different dose of LDN. And it seems to work almost as well.
You say a different dose. How different? What kind of dose?
So I've heard there's been some weight loss clinics who've used LDN at 4.5 milligrams twice a day.
Okay.
So that's kind of the dose that I target for patients who also have issues with food cravings and weight issues.
Interesting.
Yeah, and that seems to work. That seems to work pretty well. I've gotten some pretty good feedback. I think you still get most of the benefits from like anti-inflammatory and the autoimmune effects, but you also get this added benefit of the craving reduction to encourage weight loss.
That's amazing. Well, we'll have to talk to you again before 2 years. We'll see if we can do it next year. But we've run out of time. And what can I say? It was amazing talking to you. Thank you for being my guest today.
Sure. Hopefully, the next time we speak, I can have a little bit more formal, information in terms of, putting all this patient data into a little bit more formal, data, so that it's a little bit more readily accessible.
Well, what you really need to do is to get all your patients to use the LDN app, which is free, and they can add all their information. They can give you permission to access their data through the LDN hub, and it's all there at your fingertips. All the patients that are using the app, you can access their data. You can't alter it or anything, but you can view it. And then if you wanted to, you could actually select all the Hashimoto's patients, and then you can do graphs and charts and see who's doing well. It's all there at your fingertips if you were to use it.
I've known about the LDN app, but I have not had a chance to promote it. So thank you for the reminder. What I'll do is I'll probably have to send out an email to my patients and that would asking their.
Exactly. That will. You have to register for the LDN hub. I'll send you the links later, but it's free to the patient. You get a year's free to start with for the LDN hub, and then we only charge you annually for the number of patients that are active. So, and the cost is very minimal. It's just to pay for itself, but it does mean that you don't physically have to do anything. It's all done for you. So it might be a help.
Yeah, absolutely. I mean, I've learned a lot since the last time we've spoken in terms of LDN. You really only learn this stuff by experience and prescribing. And, my methods have changed over the last 2 years in terms of prescribing. The insights that I get from patients over the last 2 years has been very helpful. I can only imagine, the next couple of years where the whole, where LDN will be. I've seen a very good uptake in patients, requesting LDN, and I think it's only going to grow. The community is only going to grow larger and larger, and that's all for the better, I think, for all of us.
Well, thank you very much.
Well, thank you for having me.
Would
Would you like a consultation for an LDN prescription without leaving your home? Good news, ldndirect.com can do just that. Consultations are available in all 50 states and parts of Canada. They are waiting to help you improve your health. Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.